welcome, and the field is for you, Dr. Ilham. Thank you very much.
Thank you. Thank you, Dr. Ahmed, for introducing me. Assalamu alaikum and good morning, everyone. My talk today is the pediatrician's role in preoperative management. 1 minute. دقيقة بس لأنه I can't move my slides.
Click على السلايد it will move. Make click only على الفيل.
Okay, thank you.
Welcome.
General anesthesia and surgery are stressful situations which might precipitate decompensation in a previously stable medical condition, for example, in diabetics or children with controlled epilepsy. The perioperative fast also poses a challenge in patients with metabolic and renal disease and other problems in children. We also have the problem with bleeding and coagulopathy and risk of infection. All these are encountered in surgery in normal or children with comorbidities. The preoperative screening is usually done by the anesthetists and surgeons in preoperative clinics. Patients are referred to the pediatrician if an undiagnosed medical condition becomes evident during preoperative screening, or for optimization in patients with known comorbidities, or to rule out associations, for example, in patients with syndromes, sensorineural hearing loss, cataracts, etc. These conditions are usually more known to the pediatrician than the surgeon, and we are the ones who are able to pick up associated problems or medical conditions which might come later in life. So our preoperative consultation helps streamline the day of surgery by eliminating the preventable causes for cancellation and delays of surgery. It helps optimize medical management, helps familiarize child and parent to the hospital, and it enhances the utilization of OR time, as well as hopefully reduces unplanned postoperative PICU admissions. It obviously would be very helpful if the screening is done in ample time before the date of surgery to give us time to deal with the comorbidities and other things which need to be stabilized before surgery. Because as we know, it's extremely hard and really non-empathetic to cancel surgery the day before. Since the family had already sometimes taken time off work or school, they might have been on a long waiting list. And also, they are emotionally prepared for the time of surgery. So to cancel the surgery the day before surgery is really traumatic and stressful. So our primary steps are to address comorbidities and their possible effects during the perioperative period, to manage any concurrent acute interceding illnesses. Our key concept is that the child should be in the best possible state of health, given the child's underlying medical condition when he or she presents to the operating room. So as in any successful consultation, we need to take thorough history from the perinatal period and full examination. Medical reports from patients with comorbidities treated in other hospitals are essential, and this is usually difficult to get. And then we have to plan our investigations and referrals accordingly. And we have to limit those to those which are necessary to the surgery to reduce the stress and unnecessary referrals. There are important four points in the history. Anesthetists usually care about those, and they ask themselves. But if we see the patients first, then we might alert their attention. History of malignant hyperthermia, prolonged paralysis after receiving succinylcholine, bleeding diaphysis, and postoperative nausea and vomiting. As I said, these are usually important to the anesthetist, and they usually ask about those because malignant hyperthermia can be potentially catastrophic in predisposed patients, so they need to avoid certain anesthetics in those conditions. Medication history is extremely important. Most regularly prescribed medications can be taken with a sip of water on the day of surgery and not violate MPO standards. Conversely, non-prescription medications and herbal supplements may pose potential risk of bleeding or drug interactions. And also over-the-counter medications and supplements should be stopped before surgery unless there is a specific reason to continue them. For example, aspirin in certain patients with cardiac conditions. There are some important medications which we really need to pay attention to because you might need to change them or upgrade or give a loading dose, like anticoagulants, anticonvulsants, immunosuppressive medications, and steroids. I will go by discipline. So for cardiac disease, a cardiac evaluation is recommended in all patients with symptoms suggesting cardiac disease. For example, failure to thrive, low exercise tolerance, recurrent respiratory tract infections, and certain syndromes, which we know that they're associated with cardiac conditions. All asymptomatic patients with a clinical assessment indicating the potential for underlying cardiac disease, including all patients during or shortly after chemotherapy. Also children with a new heart murmur during examination, unusual electrocardiographic findings like a prolonged QT interval. And this one we worry about in King Abdulaziz because there is a rare association with sensorineural hearing loss. Also patients with neuromuscular disease like Duchenne muscular dystrophy, and children with known and maybe operated on cardiac disease, congenital heart disease, like history of repaired tetralogy of Fallot. As we know, there is airway anomalies are really serious. Few things are more dangerous than difficulty in maintaining a patent airway or being unable to intubate a patient. Therefore, it's imperative that the pediatrician informs the anesthesia team of all patients with airway disorders. And the red flags are previous difficulty with intubation or mass ventilation, syndromes like Pierre-Robert, Treacher-Collins, Goldina, Down syndrome, Klippel-Flare, mucopolysaccharidosis. All those have impaired airways. Also previous history of airway or cervical spine surgery, or prolonged intubation during the neonatal period, or stridor at rest. In the respiratory disease, importance point to the anesthetist are history of chest or airway surgery or upper airway malformations, history of bronchopulmonary dysplasia, and those we have to optimize the respiratory function before surgery. So you might need to prescribe beta-2 agonist or evaluate cardiac function, and also assessment of electrolytes if they are treated with diuretics. A history of sleep apnea is crucial, and because we need to organize postoperative monitoring for 24 hours. We need to consider cardiac evaluation and/or sleep study prior to surgery. That depends on the severity of symptoms and surgery itself. If we have an acute upper respiratory tract infection in an otherwise healthy child without systemic or lower respiratory tract symptoms, this is not usually grounds for cancellation of surgery. Obviously, this decision is up to the anesthetist, but normally they're not grounds for cancellation. Conversely, upper respiratory tract infections that are accompanied by fever, wheezing, or productive cough are likely to lead to cancellation of elective procedures. Patients scheduled for non-emergent procedures who are recovering from respiratory illness in the last 2 weeks, they are taken on a case-by-case basis. But we need to give detailed information about the chest and upper airway examination. That will be helpful to determine the type of surgery, time of surgery. Asthma is very common. Treatment options prior to surgery are based upon the level of severity of the disease. So frequently all that is needed is a short-term step-up in the treatment regimen. For controlled asthmatics, we may only need a short-acting beta agonist prior to surgery. Moderately controlled patients should add inhaled corticosteroids to their beta-2 agonist 1 week prior to surgery. And the poorly controlled asthmatics may need to add oral corticosteroids to the regimen, when we might need also to consult their pulmonologist for advice. In the central nervous system, most important are patients with seizure disorders, and they should take their anticonvulsants as scheduled. Notation of the type of seizure, medication, and a brief description of a typical seizure may aid perioperative care providers in recognizing a seizure, and speed treatment. We also have to, we don't really need to routinely do preoperative levels unless this is required in the patients who are expected to stay long in PICU or long postoperative fast MPO period is prolonged. In those cases, we have to make sure that we have a parenteral substitution for the anticonvulsant. And if we don't have that, so we have to consult the neurologist for the perioperative alternatives. Anesthetics are usually suppressive for seizures, but sometimes the stress of surgery can precipitate breakthrough seizures, even in controlled epileptics. And we need to pay attention to that and observe those patients closely. For patients with neurologic deficit, we should describe in detail the neurologic deficit so that changes could be recognized in the perioperative period. So if someone develops an added on hemiplegia or something during anesthesia or surgery, that should be recognized if there was a detailed description of the neurologic deficit. For children at risk of cervical spine instability like Down syndrome, mucopolysaccharidosis, etc., results of cervical spine radiographs or history of symptomatic instability should be clearly identified for the surgeon and anesthetist. And all patients should be treated with caution, especially Down syndrome patients, because cervical spine radiographs do not exclude the risk of instability. In muscular disease, muscular dystrophies merit special attention because their multisystem effects have profound implications for anesthesia. Special approaches to anesthesia, such as the avoidance of exposure to inhaled agents, are often necessary to avoid malignant hyperthermia. Other complications in muscular dystrophies are arrhythmias, cardiac insufficiency due to the cardiac and pulmonary limitations pronounced in the older patients group. And children with hypotonia who do not carry a formal diagnosis should be identified so appropriate precautions can be taken. In many of these cases, mitochondrial inborn errors of metabolism are being considered in the differential. In these cases, an anesthetic approach and fluid management are different from that for muscular dystrophy. Therefore, any relevant data, including a specific metabolic deficiency, are helpful. And these are common. Children with hypotonia and sometimes are missed by the anesthetist and important for pediatric evaluation. For the hematologic patients, histories with hemoglobinopathies such as sickle cell disease should include medications, any previous serious complication like acute chest syndrome, any crisis, and opioid treatment. And we need to also to actually make the advice clear to the anesthetist that they have to pay attention to pre and post-operative hydration, oxygenation, temperature control, risk of infection, and thromboprophylaxis. For children with hemophilia or von Willebrand disease and other factor deficiencies and platelet disorders, a history of complications and treatment algorithms are critical. So a plan for perioperative management should be coordinated with the child's hematologist and clearly delineated. Also, children with thrombophilias, like with the factor V Leiden deficiency or genetic thrombophilias, that increase the risk of deep vein thrombosis. The history should include any thromboembolic events and medications used for treatment. Central nervous thromboembolic events should be carefully described, along with any residual neurologic deficit. And laboratory studies and perioperative preparation should be tailored to each disorder in consultation with the hematologist. Former preterm infants, and we also have many of those since ROP is a common problem treated in King Abdulaziz. When compared with infants born at term, former preterm infants less than 37 weeks gestation are estimated to be at higher risk of postoperative apnea and bradycardia after general anesthesia until a post-conceptual age of approximately 6 weeks. So overnight stays should be advised after surgery. It cannot be day surgery. And physical signs in children with sequelae of preterm birth, like bronchopulmonary dysplasia and neurologic deficits, should be noted to establish a baseline for comparison to aid in intraoperative planning. This is also a common problem for us in King Abdulaziz. patients with uveitis who come to surgery are also usually on long-term steroids. It's widely recommended to administer a stress dose of corticosteroids to patients who receive long-term oral steroid therapy, usually long-term supraphysiologic steroid therapy, like more than 2 weeks, and up to 1 year following the discontinuation of corticosteroids. And we need consultation with an endocrinologist, as the dose should be adapted dependent on the duration and severity of surgery. Diabetes is also a big problem before surgery. For patients with diabetes, the key perioperative issue is how well controlled is the diabetes. A patient with poorly controlled diabetes mellitus may need to have elective procedures postponed until blood sugar concentration is controlled. It is critical to coordinate care with the patient's endocrinologist and anesthetist to ensure optimal insulin management during the MPO interval before surgery. And patients should be advised to arrive especially early on the day of surgery to allow monitoring of glucose, to adjust insulin administration, and to begin administration of dextrose-containing intravenous fluids. Inborn errors of metabolism, although rare, but also very important before surgery due to fasting before surgery. So patients with metabolic disease pose 3 general issues for optimal perioperative management. The first is the effect of the preoperative fast, which may have to be modified or supplemented with an intravenous glucose infusion. The second issue pertains to the downstream effects of the particular disease, such as seizures, airway involvement, or developmental delay. Finally, the potential adverse effects of intravenous fluids, glucose, and certain medications must be considered. It's important, very important, to arrange early consultation with the metabolic specialist and the anesthetist to be for careful perioperative planning, because inborn errors of metabolism, they're very varied and many, and really need the input of a specialist for their perioperative treatment. Renal disease is one of the diseases which pose problems in the perioperative period and fluid management and electrolyte, because obviously of the perioperative fast. Examples are Bartter syndrome, renal tubular acidosis. We have to really control their potassium and other electrolytes carefully before surgery. And I learned in Abdulaziz, like every syndrome is associated with sensorineural hearing loss. We have Bartter syndrome with sensorineural hearing loss, renal tubular acidosis with sensorineural hearing loss. So many syndromes we see there who need to be really stabilized before surgery. For patients with renal insufficiency or failure, 3 major classes of problems are important in the perioperative period: electrolytes imbalance, fluid status, and associated medical conditions. So all those we have to treat and put plans for before the surgery. Although mild to moderate hypertension does not seem to negatively affect outcome in the perioperative period, 2 issues need to be attended to preoperatively. The secondary causes of hypertension need to be identified and corrected before surgical intervention, when possible. And antihypertensive medications should be continued through the time of surgery. Exception to this rule are the ACE inhibitors, which are generally held on the day of the procedure. And the decision to administer these medications should be made with the input of the anesthetist. For oncologic diseases, there are 2 important considerations for patients who have or have had oncologic disease. First, patients with a mediastinal mass, most often with a new lymphoma diagnosis, are at risk for lethal airway or great vessel compression or on induction of anesthesia. Important signs for that include the inability to lie supine, dyspnea on exertion, a plethora of head and neck, and biphasic stridor. Hopefully the patient had been seen by his oncologist before surgery, but if not recently seen, then we need to look for those signs. Second, the treatments for oncologic diseases can have profound effects on the overall perioperative management. Exposure to chemotherapies such as bleomycin, doxorubicin, can result in long-term effects such as pulmonary fibrosis and cardiomyopathy. Radiation treatments can cause fibrosis in multiple tissues, which can result in limited mouth opening and neck movement and can worsen pulmonary fibrosis. So hematologic and metabolic perturbations are common also during oncologic therapy and should be carefully monitored before surgery. Morbid obesity, and we also see a lot of those for adenotoxalectomies. Morbidly obese patients have potential issues with positioning, airway maintenance, placement of intravenous catheters, and comorbidities such as obstructive sleep apnea and diabetes mellitus, which raise the risk profile for these patients. If a history of significant sleep disturbance is elicited, consideration should be given to obtaining a sleep study to quantify the degree of obstructive sleep apnea. In general, patients who are morbidly obese should benefit from an early consultation with an anesthetist and can be counseled that they may have a peripheral intravenous catheter placed before induction of anesthesia. Developmental delay and autism. And sometimes those patients need anesthesia even for procedures like dental rehab, even in an older age group of children. Preoperative environment can be confusing and scary for any child, perhaps more so for those with cognitive delays. So we have to talk and educate the family and child on the process of anesthesia and surgery in general. Also, parents should be queried for advice on how a particular child can be best approached by the perioperative care team. Information on triggers for aggressive behavior or comfort issues should be communicated in a preoperative note. Obviously, this is not very common, but DNR orders should be reviewed with patients and families in light of the expected effects of surgery. Sometimes even in DNR patients, you have to go for surgery to put a gastrostomy tube or to relieve some obstruction for a relief of pain. So before the OR, discussion should be made. And obviously in those cases should be hospital policy for either to suspend or continue DNR status during OR. So in conclusion, pediatricians are in a unique position to help prepare children and their families for surgery and help the perioperative team optimize care. Communication and especially medical reports stating conditions related to increased risk in the OR is important to avoid delays and stressful repetitive referrals and investigations, and provide essential information to the anesthetist to aid the decision whether a child is fit for anesthesia or not, because this is usually not our decision. It's up to the anesthetist. And shukran jazilan. Thank you for listening.
Thank you, Dr. Ilham. Thank you very much for this very nice, very informative